It sounded like it said.
Okay.
Perfect. Well, I can go ahead and get started with introductions.
Sounds good.
All right. Thank you everyone for joining us this evening. My name is Kathleen Dwanchuk. I am a second-year student at A.T. Still University School of Osteopathic Medicine in Arizona. And I'm the SGA VP there, which means I have the privilege of serving the school at the Council of Osteopathic Student Government Presidents on the Global Health Committee. And so this evening we have three wonderful physicians who are going to speak to us about their experience with Docare International and global health. And so I kind of wanted to start off by introducing them. So I'll kind of go alphabetically here. First, I'll introduce Dr. Simmet. Dr. Tyler Simmet graduated from medical school at KPNSU in 1988, trained in OMM at Midwestern University, IMFP at Yale, and medical education at Johns Hopkins. For the past 12 years, he has been at ACOM, where he oversees curriculum and assessment issues. He's credited with bringing DO schools into a new era in assessment and brought consistency to COM curriculums. The author of 8 books, 90 peer-reviewed papers, and over 10,000 tweets. He tweets at TCYMET. His work during the postal anthrax attack of 2001 is credited with changing policy and care for victims of bioterror attacks. In 1999, he identified a new genetic syndrome dubbed Irandu-Simmet syndrome. A lifelong member of Docare and previous national president, he led the 50th anniversary celebration for the organization that culminated in the opening of the first continuity clinic for the organization. He has consulted internationally for the Armed Forces College of Medicine in Egypt, the Bulgarian Public Health Service, and the WWE. He is married to Holly Simmet, who has a PhD in biophysics, and he is father to Ilana Simmet, who is 12. Next, I'd like to introduce Dr. Kelly Glazer. She earned her Doctor of Osteopathic Medicine degree from Kansas City University College of Osteopathic Medicine in 2002 and completed her residency at Providence Hospital in Southfield, Michigan in 2005. Currently, she is an associate professor of family medicine at A.T. Still University School of Osteopathic Medicine in Arizona since September 2014 and has worked as an osteopathic medical educator since 2008. One of her current roles is directing the international electives and the online global health clerkship. Dr. Glazer served on the executive board of Docare International for 10 years from 2009 to 2019, ascending to the role of past president. During this time, she guided strategic and operational enhancements that resulted in the development of the 4 clinic partnerships in Guatemala, Nicaragua, and Kenya. And next, I'd like to introduce Dr. Catherine Pinkston, MSDO, who graduated from Purdue University with a bachelor's and master's degree in nutritional biochemistry. She worked in nutrition research for 2 years, then deciding to apply her knowledge clinically, decided to attend medical school. She graduated from the Chicago College of Osteopathic Medicine in 2015 and completed her family medicine residency in 2018 at the University of Cincinnati. Since that time, she's been working in Reno, Nevada, full-time as an outpatient family medicine physician. She first became involved in Docare during her 4th year of medical school when she spent a month rotating at the clinic in San Andreas, Ixtapa, Guatemala. She has since served on the Docare board of directors in various capacities and has been clinic director for the San Andreas Clinic for the past 2 years. She has traveled to Guatemala over 15 times for either rotations, outreach trips, or various other global health experiences. In her free time, she enjoys mountain adventures with her husband and dogs, and training for and participating in ultra-distance trail running and triathlon events. So thank you all very much for being here. I'll go ahead and pass it off to you.
Thank you, everybody. We're really glad to have you here today. I was excited when Kathleen reached out and she said, no, Dr. Glazer, do you know any speakers who can talk about a continuity of care and developing clinics overseas? And I said, actually, I do. Docare has been doing that. So let's talk a little bit about that today. And I'm really thrilled to be here with a couple of my esteemed colleagues that I've known for many years through Docare. And I'm really glad that we could all be here and share with you what a joy it's been for us to be part of this development of these clinics. So we're going to mostly talk about the very first clinic that Docare developed this year. If you can go to the next slide real quick. And that is our clinic in San Andreas, Ixtapa, Guatemala. You heard that mentioned in Dr. Pinkston's bio. And that clinic provides non-emergent acute care, chronic care, preventive care, but also has several community programs that help with education and really advance health of those communities. And so Dr. Simmet was on the board when this idea was first founded, and he was one of the really early members of Docare International. So he's going to talk a little bit about his experience and where the organization was and how it came to this point of developing this clinic.
So thank you. And I wanted to talk about this 10 years after we started it, because we really backed into starting a clinic. We're DOs, we're members of Docare, and we like getting together, talking about global health, doing global health outreach trips, and being involved in areas where there are limited resources. And everybody has their own reason for being involved. But the truth is, those reasons are our reasons. The organization has different goals and different things it has to accomplish. So after 8 years of me going on week-long missions, 1 to 2 weeks in Guatemala, and 8 years of saying, you know, this is great, but we really should be doing more, we actually did do more. And what happened is we were looking at how do we celebrate our 50th anniversary as an organization. Kelly and I were talking last night, and we think we started about 1961. For our 50th year in 2011, we started planning a celebration 2 years beforehand. And we were talking about how do we raise $50,000? How do we bring everyone together somewhere in the US? And then it got down to, why are we having a party for ourselves when we're a global health outreach group? Why don't we do something more sustainable? Why don't we do more to put our values into action? And that's when we switched from a big party for us to let's build something permanent. And what we were looking at was, what were the values of the individuals? And personally, my value was I wanted to make a difference. I wanted to see the difference I could make. And a lot of times in the United States, when you're in a residency program with 65 residents or in a class with 100 students, if you don't do something, somebody else will. In Guatemala, if you don't do it, it doesn't get done. If you don't take care of a person, they're going to get sicker. So my value was I wanted to see the difference I could make. And I didn't see it in America as clearly as I saw it in other places. The other thing is, I'm a professional stranger, an amateur anthropologist. I like visiting other cultures and learning about other cultures from inside. So the missions made a lot of sense to me. The other thing is, I'm a passionate primary care provider. I think that to be a good doctor, you need to know the person you're taking care of. I value relationships and I value long-term relationships. So the principles that we were moving towards were partnership with those who understood the culture and came from the culture, the idea of doing no harm, and the concept of partnering with other people's clinics so that we were growing ourselves while helping others get better care. We had a shared worldview in Docare, and I credit Gautam Desai for helping bring me on board and helping advance it. But we wanted external validation for what we were doing. We wanted to spread the idea that primary care had great value, and that by having healthcare embedded in a culture, the culture would be healthier, stronger, and do better. We had shared experiences. By the time we started the organization to build the clinic, I had been going for 8 years, Gautam probably 15. And we had had experiences in Guatemala that matter. One of the things that happened about 2 years before we started the clinic that spurred us on is, there were mudslides in Guatemala that hurt one of the clinics we were working on. And everyone said, we should go down there. Well, yeah, we should, but who? Well, nobody had the time to go. So we said, we'll raise money and send money. And we did. But it's a different level of involvement when you send dollars than when you go yourself. And after that, we said, why don't we try and spread our outreach trips out? We were having 12 to 15 trips a year, December, January, and February, that overlapped. So we knew people who went on different missions. We saw other missions going. But the problem was the reason we went in December, January, and February is it was cold in Kansas City and it was nice down in Guatemala. Nobody wanted to go when it was raining in Guatemala, which is when the mudslides occurred. So we couldn't spread out our 15 missions, so we went once a month. That would have made good sense too. So we decided to look for a partner. And the location became obvious. We had been going to Guatemala, so we were going to commit to Guatemala. Our goals, taking the next step. One of the ideas of primary care is you embed yourself in a culture. Your people look to you for help. They look to you for care, and they look to you for healthy ways of living. The next step was to embed it in the culture so that we could do population health, that we commit to long-term, and to start from where the people were that we were taking care of, not where we wanted them to be. We didn't want to go there and do simple surgeries because that couldn't be sustained. We wanted to take care of people who didn't have floors in their houses, and by creating floors, they wouldn't have the same insect problems. We wanted to take care of tamale wrist and and weaver's knee and learn the culture so that we could become part of it. And that's when we started looking for partners there, people who knew the community, people who were embedded in the community, and people who would make a difference. So the nuts and bolts, we knew where we were going. We were looking to identify resources and do fundraising. I can tell you when we switched from a party to a clinic, it made it easier to raise money. We also went to our board and said, if you're on our board, we need money from you. Everybody on the board needs to contribute or get off the board. And even if it was just $100, that was when people had skin in the game, they had committed, and they were part of the group. The other thing with fundraising is people gave to make people happy. Dr. Cole was dean at the Midwestern Arizona School, and he brought in a lot of money. He was the dean. People wanted to make him happy. He had foundations give that didn't deal with public health at all. And they said, give us a reason to say we made a difference. Put our name on a wall, put our name on a door, on an exam room, something. But that was something that wasn't in our range of knowledge, but we learned quickly. If you want your name on the wall, we'll put your name on a wall. We need the clinic functioning. So we met for about 15, 16 months to get things going. We put together a timeline and said, we need to have $20,000 to start, $80,000 to commit, $120,000 to make sure things are going. We actually got a nice grant from the AOF. They initially said 1,000, but when we told them that we couldn't do much with 1,000, we actually got them to up it to 25,000 a year for 3 years. And they also needed their name on something, and they needed to send their board members to come, to be a part of it and to see what was being built. We had discussions with Assade and other groups to say, should we buy a building or can we rent a building? And it wasn't an area of the world where renting was really a concept that had grabbed hold. So we partnered with people who had a building there that we could add on to and put our own stuff in there. So I was going to play the video and show you. This is the video of opening the clinic in Guatemala.
Might have to click a setting that allows audio from the video. I forgot how to do that. At the top under view options, Dr. Simmet, I think there's something up there that'll enable the audio from.
You need audio better? No, that's as loud as it goes.
And then if you click the bar at the top under view options, sometimes I've seen something up there that says enable program or file audio, or I forget what the exact word is, all the way to the very top. The view options, like the Zoom screen view options.
Get out of there. I'm sorry. So you cannot hear it? Let me get out of here. I'm sorry. Exit full screen. Make it louder. Is that better?
I think so. For a second.
Dr. Simon, I think it's just playing through your earbuds, so we can't hear it.
Is it working better?
Pleasure to see everybody here today. This is really an historic day for Docare. It's this year they celebrate their 50th anniversary, and it's such a great thing to have an opportunity to dedicate this clinic. We're looking forward to working closely with Assade as partners in this and move forward. You know, for Docare, it's been a great thing. For 50 years, been doing missions. They've always wanted to establish a continuity of care clinic. And this is a fulfillment of that major goal for them. And, you know, they're looking forward to partnering with Assade, who has a relationship with folks down here, and be able to tie this in with the missions that they will continue to do in the area also. So it's a great thing for them.
We've worked for years to establish a continuity clinic. We've thought about it, we've dreamed of it, and we finally have the financial support now, the opportunity to meet the people down here in Guatemala that provide this facility. So this is something that is so exciting for us all these years, and it's now come to fruition. And we were very blessed. We have support from the American Osteopathic Association, American Osteopathic Foundation, the Student Osteopathic Medical Association, and a private foundation, the Managón Foundation, that have contributed an awful lot of money to make these things happen. So that even makes it more exciting for us.
It was always a little bit of sadness that we would get on the plane and go back to the United States and wonder what was going to happen to our friends and our osteopathic family in Guatemala. This clinic brings all of those cares and concerns and now dreams come true. And we're so happy that not only our students and our doctors, but the people of Guatemala and the patients that will come through this clinic for hopefully many, many years to come will have that continuity.
Opening the clinic has been something we've been working on for over 10 years. Continuity health and following up with patients is something that it's the way you improve healthcare. Episodic care, which is something that we all do when we come down on missions, is good, but all the disease processes that affect ultimate outcome are the ones that we've never been able to help patients with. Now, working with Assade, Docare has found a partner that not only have a beautiful clinic as far as a site, but we have a group of amazing individuals who are excited about partnering with us in order to improve patient care. So we can do all that continuity care.
Today is the day for us. And we are very happy because it means a big achievement for Assade, because we always look for strategic alliances, and this is a very big one. These clinics makes a big difference in their lives. They have medication, they have responsible doctors that don't have schedules to see them. I think that they feel happy to.
It gives us an opportunity, no matter where we are in this area, on a daily basis, we can send patients back here a week or two later for follow-up. That is what medicine is all about. So it doesn't sound like much perhaps, but it is a huge step forward in what we're trying to do in providing comprehensive care.
It really is making what we do more effective. It's bringing people together. So instead of everyone coming out here and doing it on their own and doing what they want to do for fun, we're bringing all the schools together, bring all the osteopathic physicians together so we can really make a better difference. So really it feels good because it really does bring everything together to be much more effective and to make a real difference.
People were contacting us saying they want to volunteer at the clinic, they'd like to contribute money to the clinic, they want to send supplies to the clinic. And that's a really great thing when when you try something like this the first time, you're not really sure how it's going to work out. And it's just been great how the profession, all the way to the students, to the residents, to the colleges, the folks who did missions 20, 30 years ago have contacted us saying, this is a great thing. It made such a difference in my life, and it's fantastic you're doing this, and I want to contribute to it, or I want to come to the clinic. And we're hoping we're going to see those people come to the clinic and see what they've done, what they're supporting.
Partnering with Docare and the AOA and then the American Osteopathic Foundation, we now have a source of funding and individuals who are very business savvy. So we're coupling good intents with good organization. The outcome for the patients is going to be much greater. It's also a beautiful training site for our students, possibly for residents, and hopefully it's one of many.
So that's where we started from. I will add that I went to a DO medical school, did a residency of an ACGME program, and Docare was my connection to the profession. It's where I found like-minded people, I found friends, and was able to move forward in both worlds so that you could do the MD world for academics, and the DO world was where I got people who had like-minded goals and similar ways of doing things. So Kelly, I'm going to move it to you.
Okay, sounds good. No, I agree with you too, Dr. Simmet. We're so used to calling each other by our first names. That Docare actually really has been a big, community building type experience for me in my life as well. And a big tie to the osteopathic profession, really helped me with networking in this osteopathic world that we live in. So I wanted to kind of extend on that. So, we've heard a little bit about how the clinic was developed and some of the things to consider in developing it. But now that was almost 9 years ago, actually. It's amazing that time has flown that fast. So there's a lot that goes into maintaining a clinic over this period of time too. And one of the important things, not only with starting it, but as things go along, you need to continue working with your partners and make sure that you both have a sense of shared responsibility and decision making. That's really, really important to see the success of a project really go on this long. And ultimately, it's important to make sure that what is happening is really has the community's support as well. If the patients don't come, right, it's not going to survive or thrive. And it's not going to help them either. So community support is really important. One of the things, because this was new, is I don't know if we had a really strong sense of how do we plan for sustainability when we started this. This was a lesson learned for us with our first attempt at this. And the funding structure that we set up is such that we actually pay the salary of the physician that staffs that clinic 24/7 or all year round, right? And so at this point, we really thought it was so important to ensure that care was affordable for local community members, that we continue to do that to this day and fund the salary of the physician so that costs of care can stay low enough so that anybody can access care there. And Dr. Pinkston will probably expand on that a little bit more as she talks about what it's been like in her experience to be a clinic director. So it's important to also know that when you're running a clinic, unexpected things happen. And over the years, we've had staffing changes. I think we're on our third physician there right now over the past 9 years. Sometimes people will get hired, it's their first job, and they find that they want to move on to other things. So this is quite common. And you have to be able to figure out, okay, how are we going to find another qualified physician in Guatemala to staff it? And then sometimes changes in the community happen. So our prior physician had ultrasound training, and we provided the clinic with an ultrasound machine. And the patients are now used to having ultrasound done to help with some of the diagnoses. Well, the most recent physician hired didn't have that skills. So we had to fund training for that physician to be able to develop the skills to continue the same level of care that the community was used to getting. And then there's been things that have happened, events of Mother Nature. A few years ago, we had, probably 2 years ago, some volcanic eruptions that happened, and it wiped out one of the major communities that that this clinic serves. And all of a sudden their needs weren't so much just the usual medical care that was happening, but oh, now they don't have access to water. And how do we do that? Because their water source was completely contaminated. And so we fundraised to provide filters, water filters for the community. And now, of course, we have COVID, and Dr. Pinkston will share with us a little bit about what the clinic's been dealing with on that front. And then funding supplies changed. So when we started this up, we got a big grant from the American Osteopathic Foundation. But grants are only temporary. So how do you continue to fundraise for the needs of a clinic? You have to think far in advance when you're planning something like this. And how are we going to get the donations and other funding sources? So that's really important. All right, and Dr. Pinkston, why don't you go ahead and share a little bit about your experience as the clinic director currently for this clinic?
Sure. Well, thank you so much for having me. It's very humbling to be presenting among Dr. Simmet and Dr. Glazer. Just a little bit of background about me. I first became involved with Docare in 2015. I was a fourth-year medical student at that time, and I spent a month rotating at the continuity clinic in San Andreas. And I had previously actually been to Guatemala and Belize for other global health experiences, and was always left a little bit troubled with the lack of continuity or follow-up that patients were not going to get when I left. And so when I rotated at the Docare clinic, to me, that was like the best model I could have possibly imagined, where students can go to rotate or go on global health outreach trips, but that there was a consistent presence of medical care in the community so that those patients would get follow-up. And so that's when I knew I wanted to become more involved. I'm a little bit, less removed from residency and training and such. I did choose a family medicine residency where we were actually required to do a month of global health each year. And so first year it was with my residency, but the second 2 months it was through Docare. Again, I rotated at the San Andreas clinic 2 more times, and TechPon actually 1 time. And then I also did a medical Spanish elective. I kind of created my own elective in residency in Guatemala as well. So I do want to say, if global health is something that's very important to you, there's definitely residencies out there that allow it, if that's what you're looking for. Since 2015, I started serving on the Docare board of directors. In 2018, I was asked to fill really big shoes of Dr. Shalsha, who was on the video, and step in as clinic director for the San Andreas clinic. And so clinic director has been very much like Dr. Glazer said, lots of challenges, up and downs. I will say, the clinic is pretty self-sustaining in terms of patient care. There's a nurse practitioner and a doctor there, and they're the ones that are on the ground seeing patients day in and day out. And so my role has been, multiple things, but previously, before COVID, I was traveling at least twice a year to the clinic just for communications and needs assessments and such, and then meeting on FaceTime or Zoom for multiple other times throughout the year. One of the things that we do is track clinic data. So how many patients are being seen, gender, problems, how are we diagnosing them, any diagnostic tools used. And so that way we can continue to incorporate any needs that they may need. For example, like Dr. Glazer said, we had previously had a physician with ultrasound training, and then that physician left and a new physician came in, and we were able to get fundraising for training for ultrasound for that new physician. So I'm also involved in tracking and improving student and resident rotations. And so all the feedback on rotations comes to me, and we take a look at that and try to incorporate any improvements that we can. And we'll talk about some of that in a little bit. I also just serve as an advocate for the clinic. I know the folks that work at the clinic well, and there's been times of need for them. So Fuego Volcano was in 2018, like Dr. Glazer said. The community that Dr. Glazer was talking about, their water supply basically got obliterated by ash. And so Docare at that time had a fundraising initiative for water filters. And that was something that we were able to deliver to that community. And then currently in our environment, COVID, of course. COVID has hit Guatemala pretty hard. There's been significant economic impact due to travel restrictions between departments. Departments are in Guatemala sort of like counties are in the States here. Many people in Guatemala actually travel between departments for work via chicken bus or other routes, but they've been unable to do this because of the closure between departments. And so that's had a huge economic impact in the past several months. And then even many clinics shut down in Guatemala due to the fact that clinic staff was coming from different departments. And so San Andreas has actually been able to remain open. They had to apply for special government permission to do so because the staff, again, lives in a different department than the actual clinic. But they were able to maintain and be open. And so initially, like much of us here in the States, their patient numbers dropped off pretty considerably initially when COVID hit, but ultimately it went back up quite a lot and even over what they were normally doing, just because they were one of the few clinics in the area that stayed open. And they've also been doing, we also ended up doing a fundraiser for this clinic through Docare. They've been providing a lot of public health initiatives. They're very involved in the communities around the clinic, the communities that they serve. They've been handing out hygiene and medicine kits, just kits to families that have basic things like gloves, masks, Tylenol, basic things that a normal Guatemalan might not necessarily have. And then they've even been doing some food distribution because, again, many people are just simply out of work because of COVID-19. So we are working currently on a medical Spanish elective for the San Andreas Clinic. If anyone's interested in that, some of the feedback we've actually gotten from people who are rotating are just, lack of Spanish may affect their clinic experience. And so we're currently working on a medical Spanish elective where you would spend probably the first half of the day at the clinic and then the second half of the day doing Spanish lessons. And so that's something we're going to be offering hopefully as soon as COVID allows us to have rotations again. So now just a little bit about rotations. In Guatemala specifically, there's a clinic in San Andreas, Ixtapa, and then there's a clinic in Tecpan. If you rotate in San Andreas, you're probably going to stay in Antigua, which is a pretty happening city in Guatemala, kind of a tourist destination. And if you do the rotation in Tecpan, you're going to be more remote. It may be more of a kind of a genuine, more rural Guatemalan experience in terms of where you're staying. I rotated at both and both were amazing experiences. So you can be a student or a resident to rotate. I do want to say that if you are either, you should probably kind of plan far in advance. Some schools are requiring 3 to 6 months prior advance notice if you want to do a global health rotation. Not currently, obviously, but previously. And same with residency. You have to plan for that unless you're going to a residency that allows, or wants you to do global health rotations every 3 to 6 months. And so for me, the highlights of the rotation, I might go back one slide. For me, the highlights of the rotation were working with Guatemalan doctors and just learning differences in culture. My Spanish improved a lot. In our free time, we were practicing our Spanish. We weren't just sitting around, we were practicing our medical Spanish specifically. And just, there's a lot of differences in culture between the way we practice in America versus Guatemala. It's much slower paced. There's definitely certain things and certain ways of treating patients that you won't see in America. And those are just cultural differences. I definitely saw some pretty interesting things rotating. I mean, I sewed a finger back on, I think 2 separate times after it got chopped off by a machete. So definitely things you may not see in America. Like I said, improving Spanish. If you are in a rotation where predominantly everyone is speaking Spanish, you're forced to speak Spanish, and that's really the best way to learn, in my opinion. Just experiencing a different set of social determinants of health. So in America, we talk a lot about access and that type of thing. Totally different social determinants of health in Guatemala. We're talking about people don't have clean water, they're living on dirt floors, they don't have access to food. And so you're going to see a completely different set of illnesses related to that versus what you may see in the United States. And then, like we talked about before, continuity of care. I knew that when I was leaving, these patients were still going to have good care, and that was very important to me. I love the people and the culture of Guatemala. I'm just passionate about it, and I can't wait to go back as soon as we're allowed to. And then if you're a student or a resident, just weekend activities. You're at the clinic Monday through Friday, and I think a lot of people kind of overlook the importance of the weekend activities. You can do a lot. There's a lot to do in Guatemala. So next slide. So we visited Tikal while we were there, which are Mayan ruins. Some of the other pictures here, the middle upper picture is just me at the clinic. Middle right picture, that was actually in Tecpan. We did a dental hygiene and toothbrushing session with these lovely kids, and it was just so much fun. Because I've been there so many times, I joined a running club in Guatemala, and so bottom left is me running a race with some friends down there. And then the other pictures are just us near the clinic. So next slide. There are other Docare clinics besides Guatemala. We do have a clinic in Nicaragua. There is a partnership. Well, all of these are partnerships. So we have a partnership with a clinic in Nicaragua. We have a partnership with a clinic in Kenya. And then currently we're working on hopefully getting rotations going in Mérida, Mexico as well. And so there's definitely a lot of ways to get involved with Docare. You can start a chapter at your school to learn more about Docare and advanced global health initiatives. I actually didn't have a chapter at CCOM when I was there. I just kind of happened upon the rotation by chance when I was looking for ways to rotate. But I definitely think, starting Docare chapters at your school will definitely help people get involved. Clinic rotations for sure. For third and fourth year medical students and residents as well. There's also outreach trips, obviously. I think maybe, as you advance to attending status, you probably need to do more outreach trips because those are a little bit shorter than a rotation. But, and then also some of our members on the board recently developed a global health certificate program, and more can be found with this link. But this is a great thing to put on your residency. I still want to do it. Actually, I haven't done it yet, but basically you'll do some online training courses through Coursera, and they have some great global health courses that include sustainability and other types of courses. And then you're required to attend national meetings, and then the other requirement is either a clinic rotation or a short-term global health outreach activity with Docare. This is with the caveat that we're, in the era of COVID. And so if you have completed all of these other requirements, and maybe not done the clinic rotation or the global health outreach through Docare, you can always email us and maybe get permission to do something more local, but ideally doing it internationally in the future. You have about 4 years to do this. So you can start at the beginning of medical school and finish, 4th year of medical school.
And I don't think it's limited to just med students or residents either, is it, Dr. Pinkston?
It's
The
not.
certificate? Okay, yeah.
So Kelly, we're going to let you summarize. But
I didn't realize you switched slides on me. So, anyways, I think really our take-home points for you all is that if you're thinking about engaging with communities abroad, it's important to think about what you want to do to have a focus on primary population health, first of all. Be prepared for a long-term commitment. Make sure you consider things like having mutual benefit for us and benefit for the community, and being honest and transparent about that is really important. Thinking way in advance about how is this going to be sustainable in the long run. But then also remember it is a different country. And so it's important to be flexible, compassionate, and open-minded as you go through these collaborations together. And so ultimately, though, if this is something that sounds exciting, we certainly welcome you to get involved with us on Docare in any way that works for you and that you would enjoy. So thank you. We are happy to take questions. I don't know if we said to put them in the chat. Were there any in the chat though, Kathleen?
No, there aren't any questions yet.
So feel free to unmute because there's not really a lot of us here.
I would just add that one of the things about the clinic is it was doing what was doable. We chose Guatemala because it was an easy flight, reasonable cost, and an area of limited resources. And then we developed the connection. A lot of times it happens the other way around, where there's a champion saying, we want to do this because I'm from here, or I have a connection. There are a lot of different ways of doing it, but you want to make sure that what you choose to do, you can accomplish.
So any questions?
I'll kind of get us started off with one while others are thinking. So one problem I came across when I was living in Burkina Faso with the rainy season was that people can't access the clinic because of the roads. Is that the problem in this community? Because you said, for example, the outreach trips wouldn't go during those months. But can the community access healthcare when it gets really rainy like that?
It depends on where you are. I've been to Guatemala in the rainy season in June, and I have seen many mudslides. I've seen mudslides that have wiped out entire communities like days before I got there. So it really depends on where you are. And on the short-term trips, when we knew, hey, it looks like it's going to rain this afternoon and we're in a rural village down a dirt road, we would leave before the rain would show up so we wouldn't get stranded in that community with the only one road out being blocked for us. But San Andreas Ixtapa Clinic is in a little bit more urban kind of situation, right, Dr. Pinkston? So it's probably accessible still.
Yeah, I've rotated there when the streets are literally rivers, but patients still come because the clinic in San Andreas is actually in an urban area, and that's a lot of what they serve is patients from that particular area. There are patients that come from certainly outside villages that probably wouldn't come during those times, but we were still fairly busy when even when it was totally flooded. So
thank you for your answer. We've got some questions coming in. Is Guatemala the only one currently available for going to, currently meaning after COVID, or do you have rotation options to the other clinics, such as the one in Kenya?
Yeah, so all those clinics do take rotations. And I don't know, Trixie, what school you're from, but there has been a couple of students from my school that have rotated there and had really great experiences with it. The one in Kenya is unique in a way because actually the person who runs that clinic is an osteopathic physician, a US trained osteopathic physician who's there almost all the time, you know. And so they're really the one who functions as your preceptor when you're there. So that one is a little bit different. And that partnership, like we said, each partnership was different. Our first partnership with the Assade clinic, you know, that was our first time, and we learned, okay, got to think sustainably. So some of our other partners, we have different ways that we've arranged those financial agreements so that they are potentially more sustainable and not quite so dependent on Docare. So that's one of them that is probably the least dependent on Docare. And then the Nicaragua clinic also, that's been since like 2013. I went down there in 2011 to kind of do an initial evaluation of it for the partnership. And so I believe we started that in 2012 or 2013. And that situation, that clinic's, you know, running, the physician is employed by the Ministry of Health in Nicaragua. We support it with medications and money for other supplies and functions of the clinic. And we stopped rotations there before COVID because there was a security issue going on in Nicaragua. And so we always assess what's going on beyond just a pandemic, whether a place is safe or not for student rotations. And so that one has still been an area that we're partnered with, but hasn't had rotations for almost, I think, a couple of years now. So to give you a sense of that. So rotations, for those of you who might be first or second year students, are typically year 3-4 clinical rotations where you can get course credit for it. Not all schools, so like my institution, if our first or second years go on a short-term mission trip, you know, that's just volunteer time. They don't get any course credit for that. And so I don't know if I'm totally following Trixie's second question there, but hopefully that answers that for you.
I would also share that we try to push our global health outreach trips to 3rd and 4th year. If students do it 1st and 2nd year, they're unlikely to go back. If they do it 3rd or 4th year, they're more likely to develop a relationship and to continue on. So just for sustainability of the clinic, for relationships, we talk about 3rd and 4th year.
From a skills perspective too, when you're a 3rd and 4th year, you're already, you know, getting pretty used to delivering patient care. And so it's important when you're doing these partnerships, like, well, our benefit is some learning opportunities for our students. You know, we have to be mindful to not completely burden the providers with having to train somebody who is completely dependent and maybe not helpful very much yet. So that's another reason why most global health rotations you'll find are often limited to year 3 and 4, but there are some opportunities that are available for year 1, 2. And for Docare, it depends on the trip, the short-term trips. A lot of them will take 1st or 2nd year students, but not all of them for the same reasons. So.
And there's a question about the travel grants and scholarships provided by Docare and the AOF. And I would just bring up the AOF, Atlantic International Humanitarian Grants, which are $1,500 for a trip. And I think they're about 20 a year of the Rosnick grants.
Wow, that's a lot more than I realized. That's fantastic.
There was also another question. Are there any virtual initiatives currently that students could get involved in addition to the Global Health Certificate Program, just because of the current pandemic?
Dr. Pinkston, do you have anything on that? I'm not on the board right now, so
you know, aside from the Global Health Certificate, I think that's probably the biggest thing we have available right now. You know, getting started on those first several requirements, including the courses that you're required to do and attending some virtual seminars can kind of get you started on that. And then hopefully as, you know, COVID decreases or we develop a vaccine or whatever's going to happen in the next few years, you could complete that by actually doing then an outreach program or a rotation. So I would say right now the best bet's the Global Health Certificate.
And there's another question about OMT. Did you ever use OMT in any of your rotations while you were down there?
I did, yeah. They are very open to it. So, and there's a lot of musculoskeletal problems. They're carrying around giant stacks of wood on their backs, and riding on horses and farming and all day. So there's a lot of musculoskeletal issues, and they were definitely very open to OMT.
And I would also say that the new partnership with the clinic in Merida, Mexico, that is an OMT clinic. Dr. Simmet, were you going to say more about that clinic?
Well, I was going to say that there are lots of opportunities, but there's also tiered care there. When you're meeting with the leadership, they want more intensive care and they're more open to OMT. The clinic care is a lot more rapid and not as much opportunity, but there is a lot of need out there for OMT as well.
Well, I will also just say that it's generally kind of a slower pace too in Guatemala, as opposed to America. You're not doing 20-minute patient appointments. And so you have more opportunity to practice than what you may on clinical rotations here.
Any other questions? I was thinking too, Dr. Simmet, you mentioned the travel grants by the AOF, but Docare also has some travel grants that they offer directly as well. So they're on the website. The information about that is on the website. So and if you Google Docare International, you'll get to the website.
I have one more question. Thank you so much for this amazing opportunity. Because I'm on the phone, I'm so slow to type, so I'm going to just ask. But so I know that our school has Global Health Club, but I don't know if we have a chapter. So if we want to start one, like what would be the best way to start one at our school?
No problem.
Yeah,
So,
go ahead.
does Western have
You
just
go
one
ahead.
club or do they have multiple clubs? At Western, is there only the one International Health Club?
Yes, I believe so. There's at least on the Lebanon campus, we have Global Health Club, and I don't know if it's a part of Docare or not.
Because one of the things that Docare does is when you join as a student, you join for 4 years, and you have to join to go on a mission. So you can join either individually or through a chapter at your school. I think it's better if the school has a chapter where you can work together. And we have associated with clubs that had global health as their main mission and wanted more access to rotations and other resources. So there are a lot of ways of doing it. And I'd have you call Amy Byerwalter over at the Docare office. And I'm happy to share the information with you.
Yeah,
Thank you
there's
so much.
information on the website about starting a chapter, so you can go take a look at that too. But there's been many schools that have like joint global health Docare clubs, and they kind of make it a joint club. So that's not unusual. That's the case at ATSU Soma right now.
That's perfect. I will reach out to the current leadership at the club and then share the information. Thank you so much.
All right. Well, I really enjoyed the opportunity. Thank you, Kathleen, for inviting us. And it was wonderful to talk with everybody.
Yes, thank you so much for sharing about your experience with this clinic in Docare. And thank you for everyone for coming and sharing your passions to learn more about olives too.
Absolutely. We look forward to seeing you all around in the global health world.